1 in 3 women will experience a gynecological issue in their lifetime, and yet less than 2.5% of UK scientific research funding is specifically on gynecological or women's health.
Dr. Fionnuala Barton, founder of the Menopause Medic, is a GP and accredited menopause specialist by British Menopause Society. With expertise in women's health and a compassionate approach, she helps women navigate perimenopause, menopause, and beyond with holistic, evidence-based care.
Is it more people are getting PCOS and like endometriosis, or are we just diagnosing it better these days?
I think 90% of women will experience, PMS symptoms. There are still hundreds and thousands of women experiencing and living with endometriosis and PCOS who've probably never even been to their doctor.
That is crazy. When should we kind of start thinking about perimenopause?
There's never too young an age to start to become familiar with your own hormonal rhythms.
Let's say I'm perimenopause on 40. Why couldn't I just start HRT right now?
The hormone therapy isn't going to stop the ovaries from doing what they're doing.
How do you tell the difference between burnout and hormonal imbalance?
Stress hormones, when they're high, will actually directly inhibit our ovarian hormone production. And I think the experience is probably worse for our generation, perhaps than it was, 3 or 4 decades ago.
Fionnuala, thank you so much for joining me here. Do you like that title, or do you prefer Dr. Barton?
Fionnuala is wonderful. Thank you.
Brilliant. So start from the top. Give me your credentials.
Okay, so I'm a UK trained GP, and I have subsequently subspecialised in women's health and hormone health, and I'm deeply passionate about caring for women who are experiencing hormone health issues like perimenopause and menopause, but also early menopause, PMS, PMDD, PCOS as well. And so in the last 5 years, this has been my specific area of interest. I'm also a woman, so I've got a significant lived experience. Also got lots of friends and family members who experience problems. And I think that all of that together has kind of given me a wealth of both clinical and, lived experience that helps me to support the women that come and see me in a clinical way.
Absolutely. And interestingly enough, I've really focused on menopause today because your name on Instagram is Menopause Medic.
Yes.
But interestingly, PMS, PMDD, PCOS, everything like that comes up all the time, and I'm seeing it. But I'm seeing so much more of it now. And I often wonder, because I've got a little girl myself, I often wonder, is it more people are getting PCOS and endometriosis than they ever have been, or are we just diagnosing it better these days?
I think it's a combination of both. So I think that we don't truly understand the etiology or the cause of any of those conditions. So identifying it can be really, really difficult. And talking to women who experience any of those hormonal problems, many of them will say it's taken multiple appointments, many years sometimes, to find a diagnosis that sort of helps them feel like they can identify and live with what they're experiencing. And there are likely to be a number of both environmental but also potentially genetic factors that are predisposing to it happening or occurring more frequently in the population. But I think we can't ignore the fact that finally there is more interest in women's health issues. Women have got a voice that they perhaps didn't have previously, and there are more empowered women going back to seek answers, to seek a diagnosis. And so more diagnoses are being made as a result of women having, the courage and the power to stand up and to seek that support that they need, which I'm here for.
Absolutely. Yeah, I often wonder that. Is it genetic? Is it hereditary? Maybe you're predisposed, but environmental factors are bringing it on. I wrestle with this all the time because every single member of staff that's ever worked for Elle Sera has had either PCOS or endo.
Really?
We've not had any member of staff that hasn't had one of them. And I'm like, that is crazy.
Yeah, that's crazy. Incredible. They are both incredibly common conditions. I think 90% of women will experience, PMS symptoms. I think, in terms of endometriosis, significant numbers of the population experiencing, and actually even now when diagnosed numbers are going up, there are still hundreds of thousands of women experiencing and living with endometriosis and PCOS who've probably never even been to their doctor. It shows up for me in clinic sometimes. I'll come across women in perimenopause who've got horrendous torrential bleeding. They're in, excruciating pain. And I'll be the first person who has asked them if they've had a diagnosis of endometriosis, even though they perhaps have been living with torrential, painful periods for 30 years since their periods began. So I think there's a lot of people who are undiagnosed because they haven't necessarily had the courage to seek support for it, or something that I hear quite often is that I didn't want to trouble anybody. I didn't want to make a fuss. But I'm here to tell you to trouble people and to make a fuss.
And then I'm also seeing, is it called adenomyosis?
Adenomyosis.
Yeah. And what's that?
So it's a slightly different condition to endometriosis. It's another sort of inflammatory problem, ultimately, where there is a change in the muscle lining of the womb. And so that is hormonally sensitive. So during the premenopausal years, when you're having a menstrual cycle, the change within that muscle wall of the womb can cause lots of pain during different phases of the cycle. And it can very commonly show up actually in midlife and in perimenopause as something that has developed normally in later life rather than in the earlier premenopausal years.
I mean, I'm so lucky. I really am. I have absolutely unremarkable periods in every single way.
Good.
Like, I'm just like,
long may it continue.
I'm on. Like, genuine. I don't even get a twinge. I think, Christ almighty, great. And then I hear some horror stories, you know what I mean? Even from my own staff members. And I'm like, God, it must be like torture. It must be absolutely awful. I really do feel for them sometimes. It's just
I think horrendous. It can be. And I think we still live in a society that doesn't necessarily validate and recognise women's pain. I think that there is still a sort of cultural tendency towards thinking that women are over egging it, or perhaps, their experience isn't as bad as they're saying it is. I think that I've noticed certainly there is a big shift in that, and I hope that shift continues to change. I think there have been some interesting research studies where they have tried to replicate the pain of severe endometriosis or even, PMS and PMDD type pain in men, and it's completely floored them. They've got these special machines that can kind of stimulate that pain, and you've got men sort of falling over on the floor, absolutely agonized. And similarly, there's a company that have made a device that you wear as a jacket, and it simulates a hot flush. And they took it to Parliament, and they put it on a load of politicians a year or so ago, and all of the male politicians were absolutely horrified at how terrible it was to experience a hot flush, and yet we expect women to just endure
go by the
these
window and just get on with it.
Exactly, yeah.
The problem is, if you don't get on with it, guess what happens? I mean, you obviously, I talk about this quite a lot, but you're already in like a bit of a gender pay gap, and whether you want to believe that or not, but like a maternity pay gap where you might take some time off. So your male counterpart is going to get ahead because you've taken that time off to then go and have a baby. And then if you then, finally get back to where you were on your career ladder, you're then experiencing, it's almost where you're hitting that crest and your pinnacle of your career, you're then dealing with these perimenopausal symptoms and having all these issues. And then it's just another reason to go, well, that's why I can't promote you, because you're not thinking straight.
Yeah. And is it then any wonder that actually women might not be open about what they're experiencing, or might
just get on with
minimize it, or just get on with it and put up with it and suffer through. And actually, if you need to do that in order to progress your career or achieve whatever goals it is that you're attempting to achieve, then absolutely. But don't let that stop you from seeking support to help manage and improve your quality of life if you are experiencing these symptoms, because you don't have to suffer. There are options out there for everybody that can help you experience this transition, which we'll all go through, should we be lucky enough to get to this age and stage, that can make it an easier experience. And that doesn't necessarily need to be medicine. But sometimes if you're having to keep a lid on it at work or at home or wherever, then being able to go and speak to somebody freely and openly about the difficulties that you're experiencing, I think can be really validating and helpful for women.
Yeah, even if it's just as simple as a support system of another group of women around you, if at the very least you've got that, then absolutely. I just had a lady on before you on the podcast called Leanne, and she is 49, and she said, I just hit rock bottom to the point, like, it was just the worst she'd ever felt. And on that moment, she then sought help. It was horrendous, it sounded like, anyway.
And it's such a shame that we I can empathize with that story actually significantly myself. And it's a real shame that so many women will have to reach rock bottom before they feel they can legitimately ask for help. I think there is still a bit of shame and stigma around asking for help. And I really hope that, if nothing else, people listening to this will know that there is no shame in asking for help. In fact, I would say asking for help is an enormous strength.
Yeah, definitely. There's a lot of strength in vulnerability.
Yeah.
So when should we kind of start thinking about perimenopause, menopause, and trying to prevent or help or support ourselves? You know what I mean?
Yeah.
It feels like people just go, I don't know what's happening to me. And then when they really start feeling symptoms, it's then that they're like panicking, oh my God. But what can we be doing earlier than that to try and educate or help ourselves, support ourselves?
So I think that's a really good question. And I by no means want to kind of fearmonger and sort of make this an issue that women in their 20s and 30s are kind of constantly worrying about or pre-angsting about. And so what I would say is actually there's never too young an age to start to become familiar with your own hormonal rhythms, to start tracking what's happening with your cycles, whether that is your bleeding pattern or whether it's other cyclical symptoms. And if you're fluent in what your own body's natural rhythms are doing, then actually you're going to be very tuned in when things do start to change. And I think, we know our bodies better than anybody else will. So having that intuition and instinct built in and trusting our bodies and kind of tracking from whatever age or stage you're at is really valuable, because it can give us really valuable insights into whether there is other things going on. With perimenopause specifically, I think it's important to start thinking about your hormone health in as proactive a way as possible from probably our mid-30s. So average age of menopause currently, the data which we currently have, which is out of date already in many ways, would suggest that average age of menopause is between about 48 and 52. And we know that perimenopause, that sort of ill-defined period in the run-up to menopause, can last between 2 and 8 years on average, or even up to 15 years. So, if on average we're going through it at 50, but it can be 15 years before that we start to experience symptoms, then from 35 is a reasonable place to start thinking about it. And it makes sense, because I don't know about you, but I remember in my sort of late 20s and early 30s having this message hammered into me that if you're going to have children, you need to do it before 35, because from 30 to 35 and from 35 beyond, actually your ovarian reserve is going to decline so dramatically that your chances of falling pregnant naturally will be significantly lower. And it's the same biological issue that underpins both the perimenopausal symptoms and that change in fertility. So perimenopause is happening because over the years of our menstrual lives, we are reducing the number of ovarian follicles available with each menstrual cycle. And it's those ovarian follicles that produce estrogen in the first half of the cycle. So by the time we've reached 35, if we've got not enough to fall pregnant naturally and easily, we also, logically don't necessarily have enough to be producing adequate amounts of estrogen to support all of those other really important bodily functions that estrogen is, helping to regulate. And actually there isn't a single cell or organ system in the body that isn't influenced by our ovarian hormones, estradiol, progesterone and testosterone. And so that change from about mid-35, it might be subtle and it might not be significant whatsoever, but it's a really good point, I think, to start thinking about the lifestyle changes, if nothing else. So, getting good sleep, eating well, doing, the right kind of exercise for you, doing sufficient amounts of exercise, but also getting a framework in place for managing stress and for avoiding burnout, which are other things that I see showing up a lot, and incredibly frequently in my sort of 40-plus-year-old patients, because they're experiencing the hormonal fluctuation and that progressive decline in those hormones in the context of extraordinary stress that they perhaps haven't got a framework to deal with. And that can make the situation very difficult, and it can lead to people hitting rock bottom quite quickly.
You're absolutely not wrong. I often feel this. In fact, one of my questions was, how do you tell the difference between burnout and hormonal imbalance? But I think the two go hand in hand.
I think there are some subtle things that might be, I suppose, tells in some ways, because burnout and hormone imbalance and hormone change do have a number of symptoms in common in terms of a lot of the cognitive and emotional regulatory symptoms, and indeed many of the physical ones, like the physical fatigue, for example. But some of the other symptoms that might be more unique to hormonal fluctuation would be things like changes in your temperature regulation. So your burnout wouldn't necessarily affect that thermoregulatory center of the brain. So if you're getting hot flushes, if you're getting sweats or even cold chills, which is what I was experiencing, completely threw me. I was just completely freezing all the time, and it wasn't my thyroid.
Yeah.
And then other things like, estrogen and testosterone in particular are really important to help maintain normal health and function in our muscles and in our joints. So joint pain, again, is a symptom that might be more hormone related that wouldn't necessarily show up if it was stress or burnout. And again, other physical symptoms like skin dryness, hair changes, for example, and intimate dryness and intimate changes are going to be much more specific to hormonal change over things like burnout and stress. But if you've got both going on, unfortunately, they're both going to perpetuate each other because our stress hormone system is very deeply connected to our ovarian hormone system. Biologically, from a primitive perspective, if we go back to our cave person era, it's not helpful for us to be either pregnant, breastfeeding, or carrying a newborn child in periods of, unrest and famine or, whatnot. So our stress hormones, when they're high, will actually directly inhibit our ovarian hormone production and often suppress ovulation. Ovulation is suppressed, you're going to get less estrogen. Less estrogen, your body's going to struggle, and that's going to drive your stress hormones. So they are very, very much interconnected. And so sometimes actually addressing things from as many angles as possible, so addressing the stress and the burnout as well as addressing the hormones, has an even better outcome.
Completely agree with you. I could listen to this all day. I feel like you're totally talking to me because I definitely feel like this. Now, I've just turned 40 like 2 days ago, but I have noticed loads of changes, a bit more intimate dryness. And I put it down to a lot of stress. Like my to-do list is never ending. I'm so busy. Do you know what I mean? And then my partner wants to touch me. I'm just like, get off me. Do you know what I mean? Because I'm just like, the place where I would get turned on is also the place where I keep my to-do list. And I am just absolutely not in that zone. And then we've had just nice 4 days away, and I can't tell you how much I needed that time. And I was like a different person. I didn't check my phone, didn't look at any work emails, nothing for the first time in 4.5 years. And I was like, wow, what a difference, a big difference. So I feel like I'm absolutely on the cusp of burnout.
Wouldn't it be lovely if we could ensure that we have those little breaks every so often? But I think that the world that we live in, is one that means that we don't often get to do that. Or if we do get to do it, we have guilt or we worry or we don't necessarily always switch off. And I think that's one of the big reasons why you asked earlier about why we've got more kind of hormonal conditions that, that we're aware of it more. And a lot of people ask the question, is perimenopause worse than it used to be? Or is it just that we're talking about it more? And actually, in answer to that, I would say, I think the experience is probably worse for our generation, perhaps than it was, 3 or 4 decades ago, because of the context in which we're experiencing these change, because of the pressures that women in their 40s and 50s and beyond are under now. I don't know about you, but on socials, there's a lot of talk at the moment about sort of maintaining this really hyper slim, super toned physique in your 50s and beyond. And I just think, my mother's generation weren't expected to be ripped at 50. And even if we're not buying into it consciously, subconsciously, there's a lot of messages for us as midlife women that we need to be doing it all, being it all, and we need to be doing it all absolutely brilliantly. Yeah. And actually often all on our own. I mean, we're never designed to be doing it all, and we definitely weren't ever designed to be doing it all on our own in isolation.
No, absolutely. And that's the thing. So you look even back 30 years ago, and most women, they would be in the home and looking after children, and they weren't constantly bombarded with emails, having to do the mental load at home, look after the household, look after everybody's needs, wants, everything else. Like that's another full-time job on top of everything else you've got to do.
And there's a lot of women who I see who are now supporting their daughters who are, ambitious in their careers, or for whom financially they have to be working, at a higher pressure, and who are now in their sort of 50s, 60s and beyond, and in full-term, grandmothering, roles, like caring for young children still. So having to be active and having to be strong and having to have lots of energy available to spend that really important time with their children, or their grandchildren, should I say. And whether you're somebody who is running a business or whether you're somebody who is, working on the till at Tesco's, financially, we're all under a substantial amount of pressure now because everything is so much more expensive. And so women are being, are this sort of midlife woman demographic is the most highly represented demographic in the workplace currently. And if we don't support women in every single role in the workplace, in terms of their well-being, their mental and cognitive well-being, but physical well-being as well, then, the whole of society will suffer because we are the framework on which, the whole of society is built, and we're what underpins the whole of society. And
I feel like we've seen it. I feel like we've seen it with the obesity crisis. As soon as you took 80s career girl happened, we can do it all kind of vibes. At the same time, if you look at the graphs, look at the obesity crisis, because then manufacturers and corporations came in and they started making these ready meals and everything else, and just
to make it easier.
To make life easier. And she's just busy now. She's at work. She's just grabbing something on the go, and she hasn't got time to make amazing food all the time. I would say there's a big role. And this sounds like really anti-feminist, but I would say there is a big conversation to be had about women being in the home and actually really looking after that family unit.
Or somebody being there. Yeah. So that, whoever it is that needs to be earning all the money to pay the bills and the mortgage and all of those sort of things is free to do it. But I think that is a really interesting one. I mean, I talk about metabolism, metabolic health with all my patients because it's a fundamental part of, midlife health and well-being. And actually there's a significant crossover with metabolic health symptoms and hormone health symptoms. And sometimes, you have to treat both as well as the stress and the burnout in order to optimize outcomes. But I've, spoken to several of my patients before about this sort of, I grew up eating ultra-processed foods regularly, not because my mum wanted to give me them, God forbid, she wanted me to be eating more healthily, but, it was the era of the Findus crispy pancake and, canned pop for lunch and all of these sort of things. And now I'm desperately anti all of that. But we are a generation of women who that was how we grew up. We then entered our teens and 20s and 30s, perhaps with ladette culture and it being incredibly trendy to not eat terribly well, but to drink loads of alcohol, which again will have had a substantial impact on our metabolism. And you again asked the question earlier about, why are these things more common? And there is this very sort of cliched phrase that our genetics loads the gun and our lifestyle pulls the trigger. And actually, I think a lot of women in their perimenopausal and menopausal years currently are women who potentially have had a genetic trigger, and the lifestyles that we've lived as children, teens, and in our early 20s and 30s may well have been, switching on those genes to predispose us to metabolic dysfunction or hormonal dysfunction in later life.
I feel, absolutely. And I feel like more than ever, I feel like women just use so many more products. You know what I mean? These 7 skincare routines, which are just full of chemicals and all the rest of it. I feel like we never had them 30 years ago.
No, we didn't.
We didn't have all these different creams for every single different bit of skin and body part and all the rest of it. And it's just completely unnecessary.
I think my mum, I remember, had a pot of Pond's
Nivea
cream,
or
and
something.
Nivea, the blue one with the white writing. Yeah,
exactly.
It's probably really great. Why shouldn't we all go back to that?
No,
but then I don't even know what was in that. Were there a load of parabens
and I actually read a great book called Bad Science, and he's just like, listen, every moisturiser is exactly the same. This is how you make moisturiser. Now, whatever other bits of stuff that somebody wants to put in it, but essentially they are exactly the same no matter how much you pay for it. Yeah, it's actually a really good book.
But I do think there is something to be said for the environment being the switch as well, because I think that we were talking earlier about, microplastics in our environment. And I think it's horrifying to learn how much of us already contains microplastics because of our previous exposure. And we perhaps can't do anything about what we've experienced previously, but we can be intentional about what we're exposed to now, and also what we expose our loved ones to protect them from, future problems.
Have you seen Orlando Bloom had his whole body like transfused and got all the microplastics out? It's about 30 grand.
I did not see that.
Yeah.
Goodness me. I hope he feels great. I can imagine it does feel pretty amazing having a full body full
blood transfusion. Can you imagine that? But
I wouldn't choose it, I don't think. But interesting. I'm going to look that up. That sounds fascinating.
Yeah, because I was a bit like, is this total shit? Or I don't know.
I suppose if you have, if you have a kidney failure issue, for example, and actually your kidneys, which are really important for filtering your blood, are failing, and you then need to go into hospital and have your blood filtered, it is a really effective way of filtering out all the bad stuff in your blood. So I can see why logically it makes sense. There's a biological feasibility there, isn't there? But whether it would help with the microplastics, who knows?
Yeah, it's something I'm really obsessed with. I only drink out of glass bottles at home, which costs a bloody fortune. I get them delivered. Yeah. And it costs an absolute bomb, but I'm just like, I don't even trust the tap.
No.
I just, I don't know. And I've got it in my head now. I won't drink out of anything but a plastic bottle. And then I'm like, I don't want to know if there's any plastic in it.
What about stainless steel? Are we okay with stainless steel?
Yeah, I think we're fine with stainless steel. Good. All our Elle Sera bottles are all stainless steel. I'm obsessive about that. Even like my daughter's plates and stuff like that, I won't even have plastic. Yeah. She has stainless steel or ceramic. I'm just like, I'd rather her smash it than her have a plastic one or cup. Yeah. Like I did glass baby bottles, everything.
Presumably also better for the environment.
Of course. I absolutely hate plastic. Elle Sera was always built on a fundamental of, I fucking hate plastic. I'm not having it in our business. So that's why everything was made out of brass, now glass. And the packets, which are plastic that we have to use, always make sure that they have to be recyclable.
Yeah, the pouches are, right?
And any other product that we bring out has to be recyclable, not just at the supermarket one. It has to be in the house recyclable. And that's one of my pillars of product, which is a ball ache at times, I can tell you. And horrible for my margins. Okay, so let's say I'm perimenopause on 40. I'm experiencing tiny symptoms. Why couldn't I just start HRT right now?
You could.
Why don't we?
I think there's still a lot of fear around hormone therapy. I think there's also a lot of reluctance and hesitancy naturally around using medication full stop, frankly. And I completely understand that. Everyone's got a different experience and everyone's got a family member or a friend or a story to tell about something that's been, a negative experience with medication. And particularly with hormone therapy, there has just been the most terrible PR campaign ever.
Propaganda.
So after the Million Women study and the WHR study, which were both published in the early 2000s, the findings were released to the press before the study had actually been adequately processed. And overnight, headlines across the world were saying hormone therapy increases the risk of heart disease, stroke, and breast cancer. And of course, lots of women naturally decided that they were going to stop their hormone therapy. And lots of clinicians then felt that hormone therapy was something that we needed to be very careful about, or indeed actually get as many women off as possible. And that was when I was at medical school. And so the curriculum and the learning that we got around menopause and menopause care was that we should only really use hormone therapy when absolutely necessary. And if we do use hormone therapy, we use it for a maximum of 5 years in order to minimize risk. And that was 20 years ago. What's brilliant is that we've now got an abundance of really high quality research that has debunked quite a lot of what that study found. There were a lot of issues with the study. It was a huge study. So actually there's still analysing some of the data from the study, and there's still participants from the study who've continued on their HRT, which is amazing. The data sets that we're getting from that group of people is amazing.
Wasn't the HRT that they used, it came from like horse urine or something
and
like
we don't use that sort of hormone
anymore.
Therapy anymore. Exactly. No. And it was either Premarin, which was an estrogen derived from horse urine, or synthetic estrogen, and combined with synthetic progesterones or progestogens. And we do still use synthetic progestogens in certain treatments. A lot of women need that in order to help manage other components of their hormone health. But we now have available what we would call body-identical hormone therapy. And these are medicines that are made by Big Pharma but they are put through rigorous research and clinical trials in humans to prove that they're effective at what we're wanting them to do, but they're also well tolerated. And with these body identical hormone therapy options, they have the same molecular structure as the hormones that our body produces naturally. So we're kind of giving back like for like. And these hormone therapy options aren't associated with the significant risk of breast cancer or heart disease or stroke. And actually, we now know that being on hormone therapy earlier may help to protect against some of the cardiovascular, metabolic, and bone health changes that we will see when estrogen levels do start to decline. And as I said earlier, that might start in your mid-30s. So actually, by the time you've reached your mid-40s and your GP is saying, right, now you're eligible for hormone therapy, you may have missed out on sort of 5 or even 10 years of that estrogen's protective effect on your metabolism, your bones, and your cardiovascular health.
Couldn't I wind back the clock and say, okay, I'm going to want HRT, I want all of it. I want testosterone, which is crazy how they don't really give it you in the UK. You have to get it off license. But let's say I walked into a clinic and say, I want to start HRT and I want estrogen, testosterone, progesterone, and I want you to wind back the clock so I feel like I'm 20. Can we do that?
I don't think I could make those promises, but because the passage of time is such that actually it's not just that your ovaries are behaving differently and producing hormones differently, but all of your cells have aged and all of your other organ systems have aged as well in that same kind of time frame. Bizarrely, our ovaries seem to age much quicker than the rest of us, which is why they, stop working 40, 50 years before most of the rest of our organs stop working. And actually, there's some really interesting research looking at things like rapamycin and looking at ovarian transplantation. So taking ovarian tissue from women in their 20s, freezing it and reimplanting it at sort of 35, 40 in order to see if actually you can, do these autologous transplantations in order to prolong ovarian health and reduce ovarian aging. It all sounds a bit sort of dystopian, a bit Frankenstein, but there is some really interesting research going on in that space. In the meantime, can we turn back the clock? What we can do is we can restore the amount of hormone that your body is exposed to and that your cells have available back to, normal physiological levels that you would have been experiencing in your 20s and 30s, and thereby resourcing your body in the same way that it was back then. So that in theory, your cells can all start functioning in that way again. Now, whether that will mean that you're back to that person or not is a completely different issue, because I think we all change.
Of course, but in my head, I think, God, I still feel like I'm 19, but if I knew now what I know, if I knew then what I know now at 19. So if I could be kind of preserve myself at this kind of rate physically, but still have the wisdom of a 40-year-old and beyond, isn't that the dream?
Yeah. So have all the wisdom that we've gained from our lived experience, but not necessarily have to experience
the physical aspects of it.
Change.
Absolutely.
And the cognitive change. I think that's one of the biggest problems for a lot of, for a lot of women I come across, and for myself as well. Like you in your 20s and 30s, you're just naturally quite dynamic and you can think clearly, you can be energetic and you can, do lots of things all in one go. And of course, we're all told that we can multitask, right? Because that's a female trait. And then, when even subtle hormonal changes, or you've got stress and burnout influencing your nervous system, actually your ability to do the things that you used to be able to do with ease has changed. And that can significantly impact things like your confidence, your self-esteem, and your sense of self. And actually that will then potentially have a knock-on effect on what you choose to do, because you may have lost interest in things, or you may have lost confidence in the things that you used to do. So you may withdraw and you may end up doing things completely differently. And so I would say getting those hormone levels back to that sort of appropriate physiological level in your body does tend to have a really beneficial effect on that component of things. And so often people will come back to me and they'll say, I didn't realize I'd lost who I was until I felt back in that space again. And I feel even better than I did back then, because I am now the new version of me, rather than going back to being 20-year-old me.
Yeah, absolutely. So I hear body identical and bioidentical. Yeah. Are they the same thing?
In the UK, no. I think in the States it's slightly different. In the UK, we like to keep things a little bit more complicated. So what we call body identical hormone therapy are, licensed pharmaceutical grade medicines that have been put through rigorous large-scale randomized controlled trials in humans to prove efficacy and safety ultimately, but that have the same molecular structure as our natural body hormones. Bioidentical hormones in the UK refers to what they might in the States call compounded hormone therapy. So these, again, are using similar sort of compounds ultimately that the pharmaceutical companies are using, but rather than putting them into a standardized set of medications, what they do is they take your blood tests and they look at what you might need and they compound those hormones into lozenges and creams and various different things and, give you an individualized prescription. It's the same raw ingredient, it's just being delivered slightly differently. And the big difference is that bioidentical hormone therapies aren't regulated because they are deemed to be a food supplement rather than a medicine. They're not subject to the same rigorous safety testing as a drug would be. So it tends not to be something that I recommend routinely. There are, of course, always women who we need to be thinking about, providing them with a slightly more a slightly alternative solution. And that's where bioidentical hormone therapy can have a place.
Yeah. Okay. And then obviously everyone's different. How do we know what level we should be at? Is it just trial and error?
Do you know, that is a really good question. And it's a question I wish we had more information and data on. And one of the things that frustrates me most in my clinical practice, but also broadly as a woman, is that we don't know the answer to that question because the clinical research hasn't been done. Because actually women, and particularly women over the age of 45, have been excluded from a lot of clinical research until probably 10 to 15 years ago. Because guess what? We made really unreliable study participants as a result of the fact that our hormones make our biology quite different to kind of test and measure in a randomized controlled trial setting. And it's something staggering like, 1 in 3 women will experience a gynecological issue in their lifetime, and yet less than 2.5% of UK scientific research funding is specifically on gynecological or women's health. And I find that really, really hard. But in part, that is, what makes us different as women, our female hormones, is what's also unfortunately a barrier to us accessing adequate support and care, because what makes us different makes us difficult in scientific research, and it means we don't have the answers necessarily that we need. What I think is really interesting is there's a couple of really sort of forward-thinking health tech companies, actually there's several of them, who are talking about, monitoring your hormone levels on a regular basis from a younger age, so that actually when your levels have changed. And actually that kind of reflects back to what we were saying earlier about when should you start thinking about it. Now, I think it's reasonable for you to just track your symptoms and track, your cycles, and maybe you might want to track things like your heart rate variability or your blood pressure or your temperature as kind of physiological, parameters. But there are, potentially commercial opportunities for you to be tracking your hormones on a sort of quarterly basis every year, so that actually when you do reach a certain level and you're more symptomatic, you've got your own sort of set of baseline tests that you can say, well, actually my levels are now substantially different to how they were. Now is the right time for me to seek, more medical intervention. If that's not available to you, because it is an expensive option, then, yes, at the moment, trial and error is probably the most reasonable and indeed frustrating strategy. Some of the bioidentical hormone therapy practitioners will take your blood test and they will give you a bespoke sort of regime. But even then, there's going to be a degree of trial and error because, of course, perimenopause, the nature of the beast is that you're still having a cycle,
absolutely.
You're fluctuating, and it's not a linear change, it's a fluctuant one.
I feel like some people that sell those bioidentical hormones are a bit, I don't know, it's a bit sketchy for me. And I know there's a couple of companies that are coming to mind that I've seen, and I'm just thinking, they're just pumping you loads of blood tests all the time. And again, like you're absolutely right, things change all the time. So you could go in, I don't know, middle of the month, and your hormone levels are completely different than it would be at the start of the start of the month or anything like that. And I suppose what I'm trying to say is, yeah, it's very difficult to try and diagnose something from a blood test because it fluctuates too much.
I agree to an extent, and I think routine testing isn't necessarily helpful. But my viewpoint of it is that having that information as an individual is really helpful. Even if you don't have, years worth of data, if you have some data, there can be an enormous strength of having that information to make an informed decision about something. And even though our hormones fluctuate throughout our cycle, in perimenopause, if you roughly know where you are in your cycle, then we can look at what your levels are for that phase of the cycle and determine with, fair accuracy whether that is relatively low or relatively high or reasonable or not. In the mid-cycle, it's not unusual for a premenopausal woman to have an estradiol level of sort of 13 to 1400 picomoles per litre. And so if your level comes back as significantly lower than that, then there's an issue there. But the next month, it might not be the same. So that's where the difficulty lies. But I think getting data can be really helpful.
Do you think we should test every month then?
No, I don't. I think that then that would be
too much.
It wouldn't necessarily add significant value. I think in order to avoid a trial and error situation, sometimes actually doing regular blood tests can be really valuable because it can give you insights that help with decision making. But in the longer term, you wouldn't need to be checking, nearly that frequently.
I'm like somebody who's like, I test for everything, test constantly. I've had my genetics tested. I've got another Neco Health. Have you heard of Neco?
I have. I'm on the waiting list.
Well, I've got a code.
How exciting.
You can have it and you'll get right in. You'll get bumped to the front of the queue, put it that way.
I think that is really interesting.
It's good, actually.
Yeah.
And the one thing it was brilliant for, it's a lot of smoke and mirrors. Okay. It's not as advanced as it would lead you to believe.
Okay, interesting.
Right? It's there. You can do all of the things that they can do everywhere else, right? Okay. But the one thing that is really good is it's quick, it's efficient, and my God, the skin analysis is amazing. It's actually called me back to go back for free because they were concerned about a mole. A couple of moles that I had, they pulled them up on the screen, and I mean like that. When do you ever see your mole that big?
Yeah,
and you can really see the irregular border and everything on it.
It's fascinating.
It's
isn't
actually amazing.
Yeah.
And for that, for £299, for how quick it was, it's had the metabolic age of a 32-year-old as well.
Congratulations.
Yeah, I was like, thanks very much.
Take a bow.
Yeah, exactly. My grip strength was in the top 1% of my age group and things like that. So I was like, oh my God, amazing.
And I think these are things that we don't necessarily pay enough attention to.
Yeah.
And over time, that really changes. And actually, if we're looking at those kind of things and tracking those kind of things, they're really useful markers that actually an intervention might be necessary, and that those interventions may be multiple.
And strength is a big one. I talk about it. I must bore everyone to tits on this podcast talking about strength training, but if you're not strength training, please go and do it. It's things like opening a jar, being independent, being able to hold your own body weight in both hands or something like that. And I'm so obsessive about those metrics. The one I'm going to be obsessed about is my VO2 max. I think I'm really going to get into that and really start boosting that this year.
Yeah.
But yeah, it's just to add to the list of things that I've got to worry about.
Well, on the subject of testing, hormone testing aside, I think whatever age you are, as a menstruating woman or a premenopausal, perimenopausal, or even menopausal woman, it is really valuable to have other health markers checked on a sort of, even not even on a regular basis, but every so often. And in particular, if you're experiencing a set of symptoms and you're not really sure why, then actually having a broad set blood test can be really valuable, because it might pick up something unexpected, like a low vitamin D level, for example, which most of us are walking around with, because very few of us get enough, sunlight exposure to create enough vitamin D naturally in our skin. Because if we are going out in the sunshine, we're probably putting SPF 50 on in order to stop us getting wrinkles and all of that jazz. But also other things like folate deficiencies, B12 deficiencies, particularly if you're somebody who has moved to a more plant-based diet and you aren't necessarily getting fortified B vitamins or supplementing with B vitamins. And the other one that I see showing up really frequently is iron deficiency or low ferritin. In menstruating women, we're bleeding on a monthly basis. It takes a lot of energy and it takes a lot of resource to replenish that blood. And it can really drain your ferritin, which is your store of iron. And I see a lot of women who are experiencing what ostensibly look like hormone perimenopausal symptoms that actually, when you treat the iron deficiency, will feel significantly better, particularly cognitively, energy-wise, but even with sort of musculoskeletal symptoms and things as well.
Yeah.
And thyroid dysfunction. So the most common cause of thyroid dysfunction in the UK is autoimmune thyroid dysfunction, and autoimmune diseases are represented much more significantly in women than men. And we don't really understand why, but it is likely that it relates in some way, shape to our female hormones. When your female hormones start to fluctuate in perimenopause, that can have a knock-on effect on your immune health and how stable your immune system is. And it does increase the risk of us developing autoimmune problems, and autoimmune thyroid disease can often, slip under the radar. And that needs treating in a very different way. And again, thyroid symptoms might be fatigue, constipation, skin changes, hair changes, inability to lose weight or lots of central weight gain, cold intolerance rather than getting hot and flushed.
I feel like that is me. Crikey. You've literally just I'm feeling fatigued, I'm a bit constipated, I'm like freezing all the time.
Yes.
Although I get these things checked all the time. So I'm like, I think I've got a thyroid issue. And then it turns out I haven't.
Yeah. Well, I think if you're having it monitored, then that's really beneficial. And I think this probably demonstrates the fact that it's complicated.
Yeah.
It's not ever just one thing that's the problem. It's often the interplay of all many, different
so many things. Yeah, you're absolutely right. And then I feel like I've been getting heart palpitations. And the last time I had that, I was iron deficient.
Interesting. So definitely get it
So
checked again.
I'm going to. I eat a lot of ice if I am iron deficient, which I didn't realise was a symptom.
Like
but
a pica, yeah.
Yeah.
So, yeah.
Just, oh my God, during pregnancy, it was like so irritating for everybody around me because I was just like, pint of ice, please. And I just sit there and crunch at it all day. But yeah, it's interesting, isn't it? And actually, when I had the copper coil, I had pernicious anemia.
Okay, so that's an
bleeding,
autoimmune condition, and that means that you are
so
at an
much.
increased risk in
Yeah.
that case. Because if you have any one autoimmune condition, you're automatically then much higher risk of developing secondary ones further down the line. So even more reason to keep monitoring your thyroid.
Well, I thought it was, I gave up red meat at that time. And then, and I wouldn't even drink like orange juice or any vitamin C or anything. It was just like water, coffee. That was it. So I felt like I really pulled back on my diet. Then I was bleeding heavily because of the copper coil, and I just gave myself anemia.
Oh gosh.
And then I fixed myself pretty quick though.
Good.
As soon as I, knew what it was.
Yeah.
But yeah, I was like, oh my God, what is wrong with me?
How did you fix yourself?
They gave me some tablets from the doctor, the ferrous sulfite, and then I had injections, which hurt like hell actually, the B12 injections, but made me feel instantly better. And then just changed my diet again. Went back to the red meat, back to eating loads of spinach, had my copper coil out. I was like, no, that's
I think there's a lot of people who have a copper coil because they don't want the hormonal one. Because there's this inherent fear of hormone, and I think reasonably so. A lot of people have had horrific experiences with things like the pill, and
the pill sent me mental.
Yeah, but not all pills are the same. Not all hormone contraception is the same, and certainly hormone therapy isn't necessarily the same as the pill. So it's another thing that comes up quite often for me is that I don't want to use hormone therapy because I felt awful on the pill. I gained weight on the pill, or I went mental on the pill, or my mood was difficult on the pill. And I want to reiterate that the type of hormone therapy we use to treat perimenopause and menopause, and even PMS and PMDD these days, is quite different to the high-strength synthetic hormones that we would have been used to from using contraceptive pills 20 or 30 years ago. And even now we've got some newer contraceptive pills that contain body-identical hormones too, which can be a really great option for perimenopause, for PMDD, for PCOS as well, if we want to give back estrogen that's going to help support the body whilst also kind of controlling the cycle.
My biggest fear is putting on weight.
Yes.
It has been all my life because I was a really chubby child growing up, and it was probably only when I hit like my 20s, and everyone thinks I'm mental because I can never be thin enough and whatever. Take that from you will. But yeah, I'm always like, oh my God, I need to be on a diet all my life. I think it's just my generation. Again, we grew up in that kind of like skinny era.
Nothing tastes as good as skinny feels.
Absolutely. It's just
the poster, I remember
absolutely indoctrinated in me. It really is. And many girls around me, like my friendship group, as crazy as that sounds. But my abject fear is taking HRT and putting on weight.
Yeah. Yeah.
Does that happen?
It's a real concern. And it is, I would be lying if I said it isn't something that I see play out in clinical practice. In theory, HRT shouldn't cause you to gain weight. But everybody is going to be very different. So the clinical studies that we've got and the evidence base we've got on the hormone therapy options that we have available that are sort of licensed is that they aren't associated with an increase in weight. But everyone will respond.
But is that because they didn't test for it when they were doing the studies?
No, there have been some studies that have specifically isolated weight gain as a concern. I think what's more often the problem is that perimenopause itself and hormone changes, ovarian hormone changes themselves, are something that will predispose to weight gain, and the metabolic dysfunction that we will probably all start to experience coincidentally at the same time is also something that will predispose us to gaining weight. That said, if you're somebody who took the pill and gained weight, then there may be something that, high levels of estrogen might predispose you to gaining weight, in which case when we're looking at hormone therapy, we would need to be careful about which option we choose. But the hormone therapy that we use in perimenopause and menopause is never as high strength as the hormones that you will have used for contraception, because contraception needs to be high dose hormone to suppress ovulation at the pituitary and hypothalamus level. Whereas with hormone therapy, we want your ovaries to continue doing what they're doing naturally, but we're just boosting your blood hormone levels in order to help support your cellular function across the rest of your body. So the doses are very, very different.
Yeah. If you take, let's say, estrogen, testosterone, would your body stop producing it itself?
Would it stop or would it start?
Would it stop?
No. So your ovaries will be naturally aging, and within that natural aging process, they're going to produce a variable amount in a sort of gradual, slow downward trajectory, unless, of course, you have surgical or a medical menopause, or you go through something called POI, premature ovarian insufficiency, which is where your ovaries will just suddenly stop without any obvious reason. And in those instances, there is the ovarian capacity is not coming back again. Likewise, in perimenopause, in natural perimenopause to menopause transition, the hormone therapy isn't going to stop the ovaries from doing what they're doing. They'll still be doing it in the background. We're just kind of helping to support your body in a more reliable way with the hormone therapy.
Yeah, I always wonder about that, because I know there's a lot going on about there's a lot of men taking testosterone replacement now.
Yeah.
Loads of it, actually. Not a big issue for them, is it? It's not risk. Like everybody, it's so weird with HRT. And I said this on another podcast the other day, and I was like, if you were, I don't know, had hypothyroidism or a problem with thyroid, you'd just take a medication. If you have diabetes or insulin problem, take more insulin. If you have, I don't know, something wrong with the pancreas, give you something else for that. Just why is it? And like, if somebody got low testosterone, take more testosterone. It's not a problem in every other area apart from when it comes to women's health, and they're like, it's risky, don't take it.
And I think it just that goes back to the lack of research, the lack of funding, and the sort of shadow that the Million Women study and the WHI study still have over clinical practice even today. And because there is still an association between use of exogenous hormones, either contraceptive hormones or hormone therapy hormones, and breast cancer. And breast cancer is a really emotive topic. I don't think there's a single woman I know who doesn't know somebody who has either gone through a breast cancer diagnosis or who has died as a result of breast cancer. It's something that we are all very sensitive about, understandably so. And I think that fear continues to, I think probably underpin why there is still this reluctance for medical practitioners to prescribe, but also women to choose hormone therapy. But I agree with you, like testosterone therapy in men, it's interesting because I see a slightly different side. I see a lot of men who would probably benefit from testosterone replacement therapy, but not getting access to it because either they haven't necessarily found their voice to go and talk to their doctor about it, or they have gone to speak to the doctor about it and the doctor has actually told them that there isn't anything to worry about. It's not a big deal. And so a lot of my female patients have asked me, where should my husband go to seek this treatment? Because he's been to see the GP and they've told him that he's, this isn't an issue for him. And it is. And I think that, I think ignoring any group of people who are experiencing something that makes them not feel well is a problem. I think we should, whether you're male or female, if you've got a health concern, we should validate it, we should listen, and we should explore at the very least. And if we've got options, we should use them. And I feel the same about testosterone for women. it's deeply frustrating, the discourse around testosterone replacement therapy for women at the moment.
We need it for like our cognitive function, to lean into hard situations, to have those just energy production.
Yeah, and it's frustrating because of the limitations on the research. So there are a couple of big research groups who have done the majority of the research in terms of testosterone in women. And they've got research that says that women from about 35 onwards see a decline in natural testosterone levels around 25% from the age of 35. Yet there isn't a subsequent follow-up study looking at what happens when we treat those women from 35 with low-dose testosterone, because that study hasn't been undertaken. And why has that study not been undertaken? Well, because there's no funding for it. Why is there no funding for it?
Because they don't care.
Well, I mean, that is the huge question, isn't it? And they should care because, like you said, testosterone is a really important hormone for things far beyond sexual function. At the moment, the guidelines are really rigid, and it really frustrates me that if you're a postmenopausal woman who's got a low libido that is distressing, or hypoarousal symptoms, so you can't necessarily feel pleasure in the same way, and you're optimized on estrogen therapy, but these are still problems for you, then you can consider testosterone. And I think we're limiting that unnecessarily because
there's so many other
there's going to be
for
so
it.
many other women who will benefit from it. And it's stupid, it's short-sighted to think that really powerful hormone, that chemical that our ovaries are producing in abundance during our premenopausal years, is only driving that one very particular part of our brain.
It's ridiculous.
It's
you
not.
need it for muscle tissue, energy production, everything. I would 100% have it. If I'm ever going to take HRT, I want the shebang.
Yeah, and I think in the right combination and in the right quantities, it can be such a powerful tool. And it can give women a new lease of life at a time in life when we're often made to feel invisible. Our value in society shifts and changes.
I want to look like Jennifer Lopez. Don't tell me she's not on testosterone. Jesus Christ.
It's magic, yeah.
She's just on her olive oil diet. I don't think so. She's definitely on all kinds of HRT, probably peptides and everything else. But that's the reason I love Tribulus, because I found a few studies on Tribulus that it helps you free up the testosterone that you have.
Yes.
And helps you circulate it. And I know that when I go to the gym and I've had my Elle Sera tablets, I know I can get an extra 20-30% out of my gym.
Really?
Yeah,
That's
do
fantastic.
notice it.
Yeah.
I do notice it in that moment. And I think, I can feel it. And then there's another really great ingredient called testosterone, if you've not tried that.
I haven't.
That's brilliant as well. Really good. And again, when I take that, what a difference. Do you go weight training?
I do and I don't.
Yeah, I don't do it enough.
I don't. I would say that's probably the place I'm sitting at.
Yeah.
I don't find it terribly enjoyable. I know I need to do it. I'm a runner.
Right, okay.
And I've always run. And so if I feel the need to exercise, which I do most days, my default will be to go for a run, because not only do I love it for my physical health, actually it's really valuable for my mental health and my mental clarity and my mood regulation and emotional regulation. And actually I reflected that I started running as a kind of coping strategy in my teens when I was sitting my GCSEs, and I've just always
it is a good mental clear out.
Yeah.
Had I not got such a dodgy knee, I'd still be running myself, but I stopped about 4 years ago now.
But I would say my strength training has massively improved my running.
Yeah.
And actually I'm much less injury prone, apart from when I fall over the dog, which, muscle training isn't going to help with that. But I would say recovery is much better. My speed, my pace, etc., is all much, much better. So it's something that I encourage as many women to do as possible. And it doesn't need to be going down the gym and lifting heavy weights. It can be as easy as starting with body weights in your kitchen if that's where you feel comfortable. And then, being consistent. That's the key. It's finding something that you can be consistent with, because if you don't find something enjoyable, you're not going to naturally reach for it or move towards it. And if it's difficult, if you've got to get in the car, drive half an hour and wait for a spot somewhere, then, it's not going to happen. But if you make it really easy for yourself, you can be a lot more consistent.
I need to be, I have 3 gym memberships, so I can be more consistent and I still can't find the time. And I love my PT because I just take my brain out and he looks at me and he goes, right, go on, let's go. And I just follow an instruction like a soldier. Don't talk to him. Not interested, just with the greatest of respect. Don't care what you've done on this weekend. Not interested.
Yes.
He is all about me and he doesn't take his eyes off me for 60 minutes. And it's the hardest workout ever, but it's super professional, with an unbelievable, professional thing going on, and I'm in them, and it's the only time where I'm not a mother, I'm not a business owner, no one can get me, I can't be, it's the only time nobody can get hold of me, and I'm doing one thing for 1 hour for me. But it takes me an hour to get there, an hour in there, and an hour back.
Yeah, this is a big
3
time
hours
investment. Yeah. But I bet
out
you
of my day. That is a monumental time out of my day. So so I don't get there as much as often I would like. When I get a bit more staff, I'm going to really put it into my diary.
Yeah.
Do you know what I mean?
Get the PT in the office.
Now, Dan, yeah, well, I know, I'd love that. But now Danny wants to get married. I'm like, shit, I need to get in shape.
Who are in shape.
Yeah, but better shape.
And Danny doesn't want to marry future you. He wants to marry.
No, I want to look back and go, my God, look at my arms. I want arms like, I don't know, Sarah Connor in freaking Terminator. Yes. That's my look. Or like Rachel from Friends.
Oh.
You know what I mean? That's really like, oh my God, look at her, like her arms in like the later seasons are just amazing.
Yeah,
like,
I think a strong arm is a really good thing, both from an aesthetic perspective, but also from a functional one. Yeah. And I think that a lot of us are probably quite strong in our legs because we do lots of sitting and standing and running around and all of this sort of thing. I think we probably all need to focus on strengthening our glutes because they are the biggest muscles in our body. And if we're sitting down all the time, it's problematic. But I think a lot of women do lose strength and lose tone and function in their upper body muscles because if you're not intentionally doing stuff with your upper arms other than sort of texting and, on the laptop, actually you do lose muscle here really, really rapidly. And we tend to lose muscle as we age. We tend to lose more muscle as we go through the menopause transition. And so being proactive about it is really, really important. And that doesn't necessarily need to be lifting heavy things. It can be yoga, it can be Pilates, anything that's putting resistance through your upper body as well as your lower and challenging your different muscle groups in different ways because that is where the change happens. Yeah. If you just do the same thing time and time again, those muscles are going to grow, but actually you need to be doing the whole piece, don't you? And I think finding something that gives you joy is also really important as well as being consistent with the things that perhaps don't give you joy but do give you strength.
I truly believe you've got to be lifting really heavy shit. You've got to be, and then do stuff for joy. Like if you want Zumba, great, but it ain't going to give you the physique that you want in later years. Yeah. And you're not going to be healthy and independent. That's what we all want. But go Zumba for fun, brilliant. But please go and lift heavy weight is always my mantra. And I can say it to everyone around me, my mother-in-law, everybody else, my mum, they don't listen. That generation, I feel like they're just not listening. There's a few, but not.
They were the aerobics generation.
Yeah, absolutely. Crazy. But no, I really need to get back to my weight training. Interestingly enough, Dr. Mary Claire.
Yes.
Saw her literally before we came in here. I need to stop saying literally. Christ, I hate myself. She was saying that she is now kind of she's prescribed loads of HRT and also GLP-1 inhibitors. Yeah. As a combination now. Is that because obviously the HRT can make you put on weight, but obviously the GLP-1 inhibitors are helping that weight gain? And should we be doing that as a 360 approach going forward?
I think it's interesting. So I think the future is probably going to look like that, if I'm really honest. GLP-1 is a hormone. So, GLP-1 antagonists or GLP-1As, Mounjaro, Ozempic, these medications, they are hormone, medications ultimately. But no, I think the combination of GLP-1 medications alongside hormone therapy isn't to counteract the weight gain that you'll get from hormone therapy because hormone therapy doesn't or shouldn't cause weight gain, but the menopause transition does. Right. So there's some interesting research that suggests that going through the menopause transition, so that period of perimenopause to about a year or so after menopause, women are likely to gain about 0.5 to 2 kilograms, 0.5 kilograms to 1.5 kilograms, or it's like £1 to £3 per year. Even if they just stick to doing what they're doing before, even if they're not changing anything, they're sticking to their diet, they're sticking to their exercise regime, they're sleeping well, they're supplementing well, their stress management's under control, without changing anything else.
What is it then? What is it? Because like your skeleton's not really the density might be changing, but so your body composition changes. Lighter. So you get wider. Yeah. So the changes in those ovarian hormones. So our ovarian hormones are, we have evolved over the millennia in a way that
ultimately, the hormone changes are protecting us in some way. And actually, estrogen, when our ovaries are producing less estradiol, which is the most potent type of estrogen, our body will upregulate fat cell production, and we'll start laying down fat cells around our hips and our bottom, which is where we store it subcutaneously, because fat cells can be a really great source of something called estrone, which is a weaker form of estrogen that can still light up estrogen receptors, but just not so effectively. And so it's actually an adaptation. It's a human biological adaptation to the ovarian aging process that we do naturally gain weight through the perimenopause, menopause transition. The problem is, in the context of a modern day life with perhaps a lived experience that has predisposed you to metabolic dysfunction, the metabolic dysfunction that comes with increasing age anyway, and the muscle loss that naturally comes with increasing age, all of these things combined mean that we become metabolically less healthy. We're more likely to then deposit visceral fat, which is that fat around our internal organs, which tends to increase our central abdominal sort of girth and gives rise to that sort of menopause belly. And that happens in men and women. It's not just women, but it is much more noticeable in women, and it does tend to happen through the menopause transition. And that visceral fat is particularly difficult because that is what will then predispose you to even more fat gain, because it is metabolically less active. And when we are gaining more fat here, we're becoming insulin resistant. We're not driving sugar into our muscles as effectively. More of that blood sugar is then being stored as fat, and the whole cycle perpetuates. So the hormone therapy can help to support the ovarian insufficiency and provide those hormones that might be contributing to that weight gain. But the GLP-1s are going to work via a different pathway. So they are going to change or provide a consistent amount of GLP-1 hormone, which in turn will have an effect on things like your satiety and your hunger, but also your gut function. And also, we now know from some of the sort of longer term studies on these medications that they have a really powerful effect on the brain in terms of, choices and preferences and addiction behaviors and all of these sort of things. And so they will work alongside the hormone therapy to help improve insulin sensitivity again. So when you have blood sugar in your system because you've eaten a meal, and blood glucose is our primary energy source, it's what all of our cells need to work properly, your insulin is produced by the pancreas, and the insulin is then what normally drives excess sugar into muscles to be stored. Using the GLP-1 medications will help to keep that process working efficiently, so that we then don't develop insulin resistance, or we reverse the insulin resistance that is predisposing to the central weight gain. And GLP-1 medications were designed to treat type 2 diabetes, which is metabolic dysfunction, primarily insulin resistance and hyperglycemia or high blood sugar levels. And it was in their preclinical studies 20 odd years ago, when they designed them as diabetes drugs, that they spotted that almost all the participants in their diabetic studies were losing substantial amounts of weight. And as a result of that, the drug companies who were developing them for diabetes said, well, let's license the same molecules to use as weight loss drugs. And so in midlife women in the perimenopause, menopause space, they have a double role, because not only are they helping with managing the weight gain that we will naturally experience at this stage of life, but they're also doubling down and improving our metabolic health, which is really important, because metabolic dysfunction is what will increase our risk of all-cause mortality, like type 2 diabetes, cardiovascular disease, cerebrovascular disease, cancer, inflammatory disease, everything. So they are, I think, a medication that will become much more commonly prescribed alongside HRT, or even, if we're in women who don't want to use HRT or can't use HRT, to safeguard those longer-term health issues that are important once our ovaries, stop working as effectively and change.
Yeah, I think it's so interesting, really interesting, because at the moment it's painted as a bit of a bad guy. Because the problem is you do lose a lot of muscle tissue.
Not always. Yes, there is a significant risk of that, much less so with the GLP-1 and GIP medication. So Mounjaro is a combination, and the clinicals with that have shown that most people will lose about 20% body weight if they complete their course of treatment. And actually muscle loss is minimal when taken alongside the right lifestyle changes. And those lifestyle changes are adequate dietary protein and fiber, and weight training. Exactly. And if you want to keep the weight off and you want to avoid muscle loss in the long term, then you need to be weight training. You need to lift that heavy stuff.
There's a new one. Have you seen the new one called? No, Reta. Let me ask the internet.
Yes, so that's another combination. That's a triple combination, isn't it? So it hasn't been MRHA approved yet, but I think it's had FDA approval in the States.
Yes, it has. It's come out in the States. It's called Reta. I don't know, but yeah, I'm seeing it all over the internet saying if you're still thinking Mounjaro is the way to go, you've not heard of this. And I was like, all right, what's this? I've saved it somewhere.
Yeah, and I think that just goes to demonstrate, if you think about how much investment there has been in this group of medications, which is, I think, entirely the right thing to do, because, metabolic disease is responsible for a significant amount of morbidity and mortality in Western societies and cultures. So if we can eradicate that, I think that's a really, really good thing. But why can't we mobilise some of that research funding to actually look at women, female-specific stuff, even if that is female-specific studies on GLP-1s and, other kind of GLP-1-like medications, which I think will have a significant role in women's health, actually.
Retatrutide, it's called.
Yes.
Triple antagonist peptide for fat loss and diabetes.
Yeah.
That looks interesting.
And then, in the speed at which these medications are being developed and licensed is
crazy,
unprecedented, actually. And so I think that it isn't going to be, the guidelines are quite rigid still at the moment, but I don't think it's going to be long until the drug companies actually license their products for a wider group of people.
This multi-receptor strategy sets apart from previous generations of weight loss drugs by addressing not just hunger and insulin regulation, but also energy expenditure and fat oxidation. Brilliant.
That sounds like one to watch.
It sounds like I'd love to take that. Where do I buy this magical drug?
Well, not in the UK, unfortunately.
A one-way flight to LA for me. No, I know it does look good. I'm seeing a lot about peptides recently. Loads. Are you seeing a lot about peptides?
I am and I'm not. So I have seen a lot in the
bro science market. I see loads of it.
Aesthetics and longevity space. So all of those conferences, there's lots of people talking about
BCP 157.
Yes. And I think that the likelihood is, again, they will have a role. But at the moment, we just, they've not trickled down into standard clinical practice because there's no licensed options. And I think that, although it might feel like a bit of a cop-out to say, we want a licensed option, actually it is really useful to wait until we can be absolutely certain that, a medication is effective at what we're asking it to do, and also has been proven to be, well tolerated and safe for human use in the short or even long term. And I think this is one of the concerns about many of these new medications that we're talking about is we don't have long-term data on that. Well, actually we do. In the context of the diabetes studies, there's some studies that are sort of 10, 15 years old by now. But we need long-term studies.
Yeah.
Looking at their effectiveness in a broader group of people, I think.
There is a company, I'm always coming across this, ukpeptides.com. Obviously it's research only. You can only buy this for research. I know a couple of people who bought from here. Not me, by the way. Just to make that clear. I'm too scared is my option. But I'm always looking.
That's really important because that kind of speaks to the same thing, doesn't it? Because
I think, oh God, is this like who the hell owns this business? How the MHRA letting anybody get away with this?
Well, this isn't MRHA approved.
Well, of course it's not.
No.
Well, that's why it's selling it for research only.
Yeah.
How is Trading Standards letting this happen?
I don't know.
It's got to come from somewhere. So who's the Trading Standards regulator in this country? Because I know the regulations and the compliance that I have to deal with. My fucking God, do I know? How are they doing this?
Yeah.
No, I mean, my God, we talked about Menobelly before. Jesus Christ, one of our competitors, I'll say it, Happy Mammoth, can't stand them. Their whole advertising strategy is this gets rid of Menobelly. Yeah. And as you've rightly said, it's to do with visceral fat, and that's why no supplement on the planet is getting rid of that, especially not the stuff that you've got in there.
But I don't know how
I think
can they...
it's so unethical.
How can they make that claim?
Because they're an Australian company. So they're still governed by the ASA, but they don't give a fuck. They pump out, I think they've got about 600 ads live on Meta at the moment. That's just in the UK, and that's just Meta. That's not in Germany, Australia, the US. There's their massive company. Let's say, all right, the ASA goes, oh, we've seen that, we don't like that, take it off. Yeah, no problem. And they just revise it and do it another one and pump a load of money behind that one. And it's like they can't keep, the regulatory bodies cannot keep enough with the volume that's going out there. And they're an Australian company, so they're not governed by the MHRA in the UK, and they're not governed by trading standards either because they're registered in Australia. But yes, they're under the ASA, but let's be honest, who cares about the ASA? Oh, what do they do? Pay a fine, okay, pay it and they carry on. It does my head in because I play by the rules. I really do.
And it's a question that comes up a lot, you know, from women that I come across, you know, what supplements should I use? I'm being bombarded with adverts. And it's, you know, once you've looked at something for more than a second, then the algorithm catches you, doesn't it? And it's going to keep telling you more. And then, you know, you'll open your email and there'll be another pop-up somewhere. And it does engender a lot of questions for a lot of women. And we were discussing this earlier, that one of the frustrations I have about the supplement side of things is that because you've got multiple kind of companies selling, you know, or mis-selling in the case of what you were just describing, you know, a solution in an emotional and an emotive way to a problem that women are experiencing. I often see women come to me and they're on multiple different supplements. And we don't know whether they're interacting well with each other. We don't know whether they're cancelling each other out. Quite often I'll do a kind of supplement audit, and we'll see that actually they're taking 4,000 times the amount of B12 that they're supposed to be taking, or they're taking kind of 800 times the amount of iron that they're supposed to be using, because they're getting lots of different things from lots of different products. And that's the active ingredients. And the other concern I have is that if you're taking multiple different types of supplement from multiple different sources, all of them will have been compliance tested to ensure that they don't have a dangerous amount of, you know, other things and fillers, and mercury being one, you know, heavy metals.
Yeah.
But if you're taking 10 different products from 10 different companies, how do we know that you aren't then actually ingesting toxic levels of heavy metals or contaminants of some description? And so I do think we need to be very, very careful, especially given what you've just said about how actually the regulatory standards aren't necessarily as rigorous as they could be. And I think there are a lot of women out there who really trust what they're listening to.
Yeah.
And that's, I think, problematic. So I think having a supplement regime that you know works really well and that isn't going to counteract each other and that is going to complement rather than, you know, cause harm. And I think the other thing is we've got to be mindful of what's going on with our liver. Anything that we're ingesting orally is going to be processed by the liver. And actually, if we're putting a lot of pressure on our liver, that's not going to do us well in the long term.
My other gripe is, I mean, here, I'm just on this website here, clean ingredients without artificial add-ons. That, can't say that.
Yeah. I mean,
and by the
how
way,
can
I
you?
voluntarily, right, have a external compliance company that I work with. In fact, they use me as the poster child to how you sell a supplement. You are Mrs. Regulatory, and fucking hell.
Gold star.
Yeah. And all my competitors. And they're like, well, why don't you level the playing field, dob your competitors in? I went, I'm not that kind of person. I haven't also got the time. I can't be asked. But like, you can't say that because the product wouldn't be on the market if it wasn't clean. Do you know what I mean? And artificial, whatever they're saying is artificial. Like, people have this thing about magnesium stearate. Now, we don't use it, but sometimes to have the flow agent to make that supplement safe, sometimes you need to use it. And I feel like I should educate our customers on that. We do not use it, but let me just tell you that what it actually does and why people do use it in supplements would be an interesting conversation. But yeah, I mean, I see.
I have a problem with this. Get your old self back
naturally.
TM.
Yeah.
So trademark that. But that's not natural.
No, that's absolutely
That's a drug.
Misleading. Yeah, so MHRA would be all over that.
You know, that is
no, even
a
this
tablet that contains chemicals that are that are going to be influencing your biology, but it's just not regulated in the same way that a drug is.
No,
and
so
that's what frustrates me.
That is also you're implying that this is going to have a beneficial effect on your hormones. And if it does, it's now medicine. You've crossed over into medicine, haven't you? So it should be completely illegal. And they're turning over.
I'm really pleased that this hasn't hit my algorithm, actually.
Are you
I've never seen
joking?
an
This
advert for it.
is literally
I wonder if my
the
phone's
top
listening.
seller. We'll have to beep out the company's name, Cordelia. I can't be arsed with them coming at me. I have enough legals all the time for many different things, but not this. So yeah, complete belly reset.
Oh,
Ridiculous. So I hate this company, you know, and there's loads others like it because I'm so hot on regulations these days. And I'm like on the phone to the MHRA. So the reason and also the reasons companies do this is like they can put a tiny bit of B6 in it, fairy dust amount, and now you can say helps support
brain function and energy
hormonal
and
regulatory.
Yeah.
That's how they do it.
Okay.
So yeah, it's unbelievable. It does my head in, to be quite honest.
On the subject of B6, there are actually some clinical trials that suggest that actually that can be helpful for certain hormone conditions.
Definitely
so
is.
PMS patients and PMDD patients is often a supplement that I will recommend that they take, but either as part of a multivitamin or actually as a standalone, because it can and has been shown to be beneficial for PMS and PMDD type symptoms, and also in PCOS and perimenopause actually.
My other biggest gripe is, and I know you said that like you're worried about like the heavy metal side of things. My biggest gripe is there is not usually whatever they put on the label is not necessarily what is actually in the supplement.
Oh, really?
Well, so I did a whole thing on Instagram the other day. I said, can I just show you this? I thought people would find it interesting. So they tested a load of the top 5 selling creatine gummies on Amazon. And I'm talking like they were selling 30,000 units a month. So big sellers. And in the one that was the top seller, I think they'd sold 50,000 units that month. How much creatine do you think was in it?
Oh, I don't know. 2 grams, 3 grams?
0.
No.
None.
So just a sweet?
Haribo with margins.
Oh.
Like that's what you're eating, and you're paying what 30 odd quid for it. You might as well just be eating a sweet. And I've got a problem with gummies anyway. I always say gummies are for dummies. That you can't. They're not the vitamin that you put in there because of the material of the gummy. It just like evaporates out and it's completely unstable. So I just never recommend gummies at all.
I tend not to actually. I don't know why, but I mean, I wouldn't.
No, I'm not into them at all.
Gimmicky, aren't they?
They are really gimmicky. And if you're thinking you're getting any nutritional support from a gummy, I would like honestly spend 10 minutes with me. And you
at the gym, I hope, lifting something
at the
heavy.
gym. Well, can I just tell you? Yeah, can I just tell you about a gummy? Yeah, so I'm really obsessive about these things because I've got to be. And, I want to go home at night and know that I'm doing a good job and trying to do it compliantly, legally, and not hoodwink women into buying a product and using.
So women are vulnerable to that. And I think that there is a case to be made for actually this particular market group having a bit of a protection against that kind of marketing towards them, because we want to feel better. A lot of us will notice that there's something that doesn't quite feel right. And if there is something popping up that's promising us the world, then we are really vulnerable to that marketing strategy. And it upsets me when I see that women have been preyed upon in that way. But equally, I do think the right supplement regime can be enormously beneficial. And it's often one of the things that is worthwhile doing in that earlier stage. So, looking at your nutrition, looking at your exercise, looking at your stress management strategies, prioritizing your sleep. And if magnesium is necessary to prioritize your sleep, then absolutely go for it. Thinking about whether you are managing to meet all of your micronutrient targets through your nutrition alone. And, through your food is going to be best because you're going to get other benefits when you're getting nutrients from food. But then identifying if you've got actually deficiencies that need to be treated. And if you haven't got deficiencies, thinking about where you want to optimize, and supplementing to optimize is, I think, a really reasonable thing to try. But just don't over supplement.
I totally agree. And also I'm dead against these like green juices that have got 79 different ingredients in, because there's either too low dose of them or some of the ingredients will compete for absorption pathways.
Yes.
And you're just literally weighing them out, and you spend 80 quid a month on a green juice that's absolute shit.
Yeah. Can we talk about liposomes, please?
Yes, please do. Please do talk about liposomes.
Because I've been using some liposomal products. And I do think that they are better. And the science is very clear that they're supposed to be absorbed much better, but they taste disgusting.
They do, unless you buy ours, that taste amazing. Well, we do our liposomal magnesium.
Yeah, actually, it doesn't taste bad.
No,
I've got a liposomal glutathione and vitamin C that literally tastes like eating a fart. It's disgusting.
I have a vitamin C that's unflavoured. And I have to hold my nose to get it down. It's absolutely gross.
Like you're taking a Sambuca shot.
Yeah, absolutely. I think I've swallowed worse. But no, you're absolutely right. So yeah, and then some of the other products that I take that are liposomal, and I take absolutely crazy ones, ones that are not run of the mill for my genetic brain impairments, that they have flavours in them, which really make it palatable. And then people go, well, it's got artificial sweeteners in it. I'm like, yeah, great, because otherwise it would taste like ass. So yeah, I'm a big fan of that. But yeah, I really like, I've got some glutathione at home. And also the time of the day and what you're eating it with, you know what I mean? If it's a fat-soluble vitamin or something like that, you need to take it with food. And that's the other education piece. And I think people, need to understand that sometimes you can't just go into Holland & Barrett or Costco and buy something chalky, dusty, useless. You know what I mean? People always say to me, well, I take this is another unethical company that I absolutely hate, won't mention any names, but I'm stood there filming something in Manchester and they were also filming something. And I was like, oh, who's that? And they were like, oh, it's XYZ company. I was like, all right. Selling fertility supplements.
Again, real vulnerable people.
Really, yeah, exactly. Yeah. With an actor in a white coat delivering the information. And I'm watching it thinking, that is what they're doing. Mrs. Compliant over here, who's literally like probably stunting my own growth of the business because I'm like, no, we can't put that out. No, I don't feel right doing that. Or completely.
But surely you can sleep better at night knowing that you're being ethical. And
I don't even say what
women.
I don't even say what our ingredients do. Yeah, that's how much we hold back. You know what I mean? If you want to go and Google what maca does on someone else's website, please go and do that. Please go and do that. Because we don't say anything about it. We don't say that it can have any positive effect. Do you know what I mean? Because that's what the law says you can do.
Yeah.
And also there's a wonderful thing called the Nutritional Health Register, which gives you exactly what you're allowed to say about what product. And you have to use that terminology now. And I see everybody not using that terminology and just saying whatever they want. But I just think, with AI now coming, I wanted to be ahead of the curve with compliance because they all won't be and we will be. Do you know what I mean? Because I think AI will catch a lot more people that are being flying close to the wind, shall we say.
Yeah, more disingenuous.
Yeah.
And actually the other thing I think from my, I suppose, clinical perspective is that although the women in midlife and people who are suffering with hormone health symptoms have a vulnerability, they also can see through stuff, actually. A lot of women I come across, they've got a really strong bullshitometer. And I think that is something that we all get with our wisdom, with age, in many ways.
And our lower estrogen, because now you don't care as much.
Yeah, you don't care about what people think as much, do you? So you're like, no, I'm going to call that. Yeah. And so... But there's still that uncertainty and there is still that kind of really strong pull, I think, for women to want to support their health and well-being in a natural or, more natural way. And says, I think supplements is a really, key part of what a lot of women will have in their toolkit. And I think that they can work very well alongside hormone therapy or alongside GLP-1s. Actually really important to make sure that you're on a decent supplement regime when you're taking GLP-1s because you may not be absorbing your nutrients as effectively anymore. But yeah, I think it's about equipping yourself with whatever toolkit speaks to you and, sits well with you as a person, but that is also something that you can be consistent with, both from a financial perspective and a practical perspective. And that is also helping you feel better. There's no point in, being on anything that isn't actually providing you with a benefit.
Well, and also I'm obsessed with absorption. I'm absolutely obsessed with it. And that's why, like our magnesium, we use a bisglycinate. Now, bisglycinate is really expensive. It's the most expensive out of any magnesium. So when I get people going, well, I take magnesium oxide, and I'm like, right, well, what do you want me to say? Like, I paid £10 for it. I'm like, I know it's really cheap and it's really hard to get into your actual cells. Not only that, we go to the efforts of making it into a liposomal and put it in a chlorophyll capsule because, dyed with chlorophyll, not only does it look great, but it also provides some health benefits. Yeah. And these little things are like, I'm obsessed about because I think I want to take this product myself. So I want it to be the best it could ever be because I'm taking it. You know what I mean? First and foremost, I'm customer number one. Yeah. So I want it to be great. And then if anybody else wants to buy it on top, amazing. But I'm really obsessive about these little details. And, I think that shines through. Anybody who follows me personally or Elle Sera page, that it shines through about how obsessive I am about the details. I'm
passionate
and absorption levels. And I don't want you to chuck your money away. Like women are, like I said before, we've got less disposable income. we climb the ladder a lot harder and later, and we have loads more obstacles. Please do not waste your money on some substandard rubbish that is not even going to be effective. And when people say, oh, supplements don't work, I'm like, you're not taking the right ones in the right way, the right time, the right absorption. You know what I mean? And that's, I'm super passionate about that.
And actually, on a cost perspective, I think it's worthwhile mentioning that, you know, in terms of hormone therapy, again, I've come across many women who are spending £200, £300 a month on their supplement regime. And actually, if you get your hormone therapy through your NHS GP, it's £20 a year.
Yeah.
Like my HRT cost me £20 a year. And, you know, it's helping me to, you know, sleep well. You know, my joints are working properly. I've got energy. I can think clearly again. I can remember things. Nothing's dry anymore. You know, and I think actually when you do that cost benefit analysis as an individual, that's an important thing to consider too.
Yeah, definitely. Yeah. I feel like we could talk all day, but unfortunately, Cordelia's looking at me thinking I want to go home and I should probably get back to my baby. So we'll have to wrap it up there. But I've really, really enjoyed talking to you. So knowledgeable. I feel like I could fire any question at you and you'd just be like, this. So
we'll have feel free to do it anytime.
I'm sure we will. I want to know your opinion on loads of things. I see so many things coming out in this industry. I feel like we could talk all day and we should do this again sometime.
Yeah, well, I think what's really lovely is that we both have a really strong shared passion for empowering women to have the information and have the resources available to them to live their best life ultimately and feel well and engage and exist in a way that feels really positive and optimistic. And, you know, women are important and the world wouldn't exist without us. So it's important that our health is prioritised, and in a culture and society that perhaps doesn't put us at number one, it's really important that we put ourselves in that number one position.
For sure. Well, thank you so much for coming in.
You're welcome.
Thank you.